All right. I think we are live.
Yes, we
Everything's
are.
working. Good. Testing, testing. 1, 2, 3. I'm talking, so you should be able to hear me. I'm Dr. Chris Prue. I'm the Director of Education with Digitsole. And I think there are a few of you that are coming back for more, it looks like. And so this is part of the recurring webinar series on utilizing dynamic movement assessment with Key Pathologies. So this is where I cover the utilization of the analysis, not the process of the collecting the data, but the interpretation. And we've been working on the walking analysis. So we're going to do another walking analysis today, but we've been talking about this, and I think we're gonna change it up. We're gonna change the title a little bit too, but I think we'll do something a little bit different next time, and we're either going to do a running or a jumping. So do make sure that you stay tuned in and aware. So without further ado, let me share my screen here. Okay. Whoops. It's kind of matrix looking. All right. So let me pull this one up. Okay. So this is actually another one of my patients. Just a quick background and why I chose this particular case. But so this was a pre-evaluation. So this is before I started treating this patient, and this patient originally presented as having low back pain, and I do a lot of spine conditions, but I do walking analyses on all of my patients, and we can discuss that maybe at another point, or maybe you've heard me talk about that already. So the reason basically is because it gives us a lot of movement capabilities. Now, especially when it comes to low back pain, we have a classification referred to as non-specific low back pain, and it's very common in how it's reported in the literature, as well as how we classify it in terms of the patient characteristics. And so what we mean by that is we're not really exactly sure what the pathophysiological process is of having non-specific low back pain. In other words, we can't necessarily identify a specific tissue. But when people do experience low back pain, there are some sort of consistencies. So one of the reasons for using a locomotion analysis, and I've been doing this with patients for a little over 15 years, is and it's my experience anyway, and we see some literature now that supports this notion that we can actually use a locomotion, a walking analysis, to even sort of predict. And I think that in the near future, we're going to be able to have a better sense of what is potentially causing the problem. And here's one of the challenges is that it's not a static problem; it's a dynamic problem, right? And so using sort of a full performance outcome based assessment, I think, is going to give us that ability to sort of tease out some of these issues. And you may see a little bit of that here. So this particular patient is a female. She's in her late 50s. She's 58 years old, and she's actually a pretty active person. She does come with some other conditions like fibromyalgia, but she's also a runner. She's very active in attempting to exercise as much as she can. And also one of the reasons she does that is it just overall makes her feel better and trying to take less medications for her problems. So when you pull up the walking analysis, that dashboard, it shows you across the top here, pains, walking aids, shoes. So that's some information that you can look at real quick, but you can put that in there either when you're taking the analysis, or I can put it in there now. So if the patient reports that they have a 6 out of 10, then we can put that in, and we can save that. I can put the location and things like that. So information that you can save and then sort of map that out. Now, the reason I say that that's potentially a good reason to do that, if you're a practitioner like me. So for example, a lot of my patients I see, I care for them for years and years and years. So they come to me for various conditions and problems. So putting that in there helps to separate, when and why they came in for a particular reason. Also, any walking aids, if they're using a walker or cane, and then also any special type of shoe wear. I do like to note the shoes that I'm testing patients on. I've showed this in the past too, and I'm going to talk about this again in a future episode. But so shoes make a difference, right? They're something that we can use to enhance or make our locomotion worse, and that if you are going to be retesting and comparing people, then it's going to be important to make sure that you take that under consideration. So a little bit further down on the dashboard, we see that we have symmetry, cadence, and speed right across the top. They're very simple and easy, but they're pretty important characteristics of someone's ability to perform walking. Well, why walking again? Well, as I mentioned earlier, that walking encompasses it pulls in many of the systems of the body together to perform something that seems like it's very simple, but arguably it's somewhat complicated. But it's something that is innate. So it's inside of us. It does incorporate voluntary movement patterns, but there's a lot of reflexive components to it as well. Not only in just the biomechanics, but in other aspects of the neurophysiology of respiration and heart rate and things like that. So there's a lot of reflexive components to it. So one of them is that we are supposed to be very similar from the right to the left. In other words, having symmetrical anatomical features, but also having symmetrical performance outcome as well, based on those features. So the symmetry characteristic, if you put your cursor over the question mark, it actually identifies what these metrics biomarkers are. So if you're not familiar with them, and then you can also up at the top, you can download and look at some of the different interpretation manuals. So if you click on the interpretation manual, it will bring you to the website, and you could download the interpretation manual for walking, running, or for the jumping. So back to this. So we see that symmetry, cadence, and speed. We see that symmetry is actually in green. And so that green color is meant to be representative of a positive outcome. And that positive outcome is the percent symmetry. And the symmetry is based on ground contact time, right? During that stance phase. Again, really simple metric, but it helps to identify at least the earlier aspects of whether or not someone is moving appropriately. So we see that that's in green. So I always glance over the things that are in green, and look mostly for things that are in red and then yellow. So red means that it's outside of the normative values, and the yellow means that it's approaching those normative values outside of one standard deviation. So you can see that her cadence here is below normal, as well as her speed. And of course, your cadence is going to be a component of your speed, um, with the length of your steps. So it's steps per minute. And you see this in red. Now, let me explain something too. It's in red because of what I did. So sometimes I have people walk over the ground under their own speed. Um, and I do that most of the time. But this particular patient, because she is active, I wanted to control that a little bit. Like, as she says, she doesn't really experience pain at slower speeds. She still exercises, she still runs, but her pain level is sort of is sort of variable. So what I like to do is sort of a baseline level at a speed that arguably people that should be pretty active should be able to accomplish normally. And then what I typically do, and why I chose this patient to show you, is is I then have them go at another speed. So at her age, the average speed she should be able to walk at three miles per hour, at 5.1 kilometers per hour. And so if I bring her below that normal speed, theoretically, she shouldn't really have a lot of problems. Or if she does have problems, it might be easier to see some of those problems that aren't working appropriately in her mechanics, and she's not experiencing pain. Now, I talk about this a lot in the past that even when we look at low back pain, it's actually, as I described, the non-specific nature of low back pain in its generation and its pathophysiology is that um, it's not about pain, it's actually about function is the main reason that people actually come in. And so I want to look at the function, and if I can reduce that level, and test her function where she's not experiencing pain, then I might be able to get a little bit more information from this. And that's the reasoning behind that. I'm going to show you another test that we did almost immediately after. And we had her walk at that higher rate. So we had her walk at, we increased that speed to 3 miles per hour or 5.1 miles per hour. So based on this, that's why it's showing up in red. And again, I'm okay with that. I know she's capable of doing that in normal ground walking. So let's look at her walking profile. So the walking profile includes the stance phase and the swing phase and the double support phase. And so just at the standard view, it breaks down the left and the right. Now, some people get confused with these colors. These colors are just to separate the limbs in terms of left and right limb. So they're not indicating necessarily a good or a bad thing. Although we see that she does have a swing phase that is being represented in a color. So the average phase, or the percentages, it's on average about a 60% in the stance phase and a 40% in the swing phase. Well, she's purposely walking slower. And so that's why she's going to be spending more time in the stance phase. So again, I consider that to be okay, but because it's at that lower level, she should have pretty good control over this, and it really shouldn't cause much of a problem. So we see that it's very similar between the right and the left. We see that her double support phase is a little bit long, and that makes sense again because she's walking relatively slow. If you click over here on the advanced, we can then break down this walking profile, and we get a more detailed view of this. So we get the stride duration, stance, and swing time in specific numerical values, and then we also get the stride length, which is already represented in that walking profile, but now it shows within the graphical representation where it actually falls in the normal or not normal. So as we can see here, her stride duration is relatively long. And again, it's because she's walking slow. She's just on that edge of being, sort of within that normal. We see that her stride length is on the shorter side, which again, because of her speed, it's going to be shorter. And let me define that a little bit better too. How do we know this? So the system takes the anthropometric measures, right? The measures associated with that specific individual based on the age, gender, height, weight, and shoe size, right? So that's why it's important when you input that information that you do it appropriately, because within the system, the algorithm uses a specific normative range for these characteristics, right? And that's how we know specifically for this particular patient where she's falling within the range. She's not actually falling down, but and then we have swing time, which is again pretty close to the normal, and based on her stride and her overall time for each stride. And then her stance time we see is a little bit long, which again, I would expect it to be a little bit long because she's walking a little slow. Nothing really unusual here that I didn't already anticipate because I created this environment for her by making her walk a little bit slower. So now we can look at some of those other characteristics that, again, she shouldn't have a problem with because she's walking a little bit slower. Although sometimes when you make someone walk much slower than they're used to, um, they need to adapt to that, and why you may want to take that into consideration of using something that's too slow or using something that's normal and then a little bit higher. Now with an athletic population, that's what I typically do, is I take them at that normal level and then I push them a little bit higher to increase the stress load, right? But people that have a condition, you got to be a little bit more careful because, well, they have a condition and we don't want to make them worse. So looking at the gait line, her relative percentages are fine. So as she's going through that stance phase, she's doing just fine. We can see that when she loads, I'd rather that she stayed on the outside of her foot, the lateral aspect, just a little bit longer instead of transitioning too quickly. And we're going to take another look at that. So the gait line, if you put your cursor over the question mark, so that's the trajectory and center of mass throughout the stance phase, right? So that's how she's applying pressure to her feet as she's moving from heel strike and going to the toe off, or the beginning of the swing phase or propulsion. So we see that she's a little bit on the inside. Now that may relate to being a little bit more pronated, but we'll have to see that in a moment, and whether or not that is something of an issue. So then we go over to propulsion rate. So propulsion rate is the ratio of involvement of the hip flexors and the plantar flexors when you are in the late stance phase and going into the early swing phase, right? So during walking gait, right, you toe off and then you lift that foot and then you go into that swing phase. So part of that is going to be from the plantar flexors propulsing the lower aspect of the limb, and then the hip flexors are actually going to drive that leg um, into that hip flexed position. And that's why it requires both of these, and why there's an actual ratio between these two. So I mentioned earlier that she's 58 years old. So she's not old. And as I also mentioned, that she's pretty active and she is a runner, but she seems to have this chronic low back pain problem. And what we see here is there is an increase in using plantar flexors, even when she's not walking that fast. Okay. And so, what would actually typically happen for someone who's mostly normal is they should be fairly normal in terms of the ratio, and possibly even use more of the hip flexors to bring that leg forward, because they're not going through large ranges of motion when they're walking that slow, because their step and stride length are actually shortened. But we see here that she's using a strategy where she's using a lot of her plantar flexors. And I think you heard me say this the first presentation we did in September, was it? And that one of the strategies that we see in older adults is they tend to use more propulsion ratio in their plantar flexors than they do in the hip flexors. And one of the suspected reasons for that is they have lower core stabilization because they have lower core strength. And one would think, someone who's pretty active should have good core stability and good core strength of the musculature in her torso. And so, at least at this speed, it's saying, she doesn't seem to be using her hip flexors a whole lot. So she's using this plantar flexor strategy. So people that have that lower core stability tend to use that sort of strategy. And we also see this typically in people that are experiencing low back pain, because when you increase, that torque, especially in rotation, it becomes uncomfortable, and people don't want to do that either consciously or subconsciously. So this is leading us down the path to say, okay, so she probably has some core stability issues, which is causing some of these problems. So let's go back up to the top here, and across the top here, you can see some of the information. I'm going to click on the details view. And when you click on the details view, it gives us a little bit more information. And what we have here is pronosupination angles, or pronation supination angles. And as I've discussed in the past, that this is looking at the foot as sort of a single rigid model. So we're looking at more so what's going on in the foot in a shoe as they're going through that stance phase, from heel strike all the way to that toe off position. So this gives you the actual angulation between these two. So click on the advanced view, and then you get this graphical representation. I mean, I love looking at numbers, but a picture, as we say, is worth 1,000 words, and a picture can shorten the time that you may spend having to evaluate a profile. So as we can see here, you can actually take your cursor and hold it over each one of those points, and it gives you that exact numerical value that you see up here. Okay. The other thing it does is it gives you the min max, which is actually not min max, it's actually standard deviation. And so it gives you the variability through that stance phase, right? So the first point is on heel strike, foot flat position, heel off, and then into the toe off position. And you may have noticed this green shaded area right here. That's something that we have in our system, and that's considered the corridor, the green corridor of a normal pathway, a normal trajectory through that stance phase. Okay. And so what this means is a negative angle, right, on heel strike means that they are on the outside of their foot, right? So that's also known as calcaneal inversion, right? So the bottom of your feet are facing each other. That's going to be inversion. And then typically when people go from heel strike into putting their foot flat, they neutralize that, right? So it goes into a more neutral position, not eversion, not inversion, not supination, pronation, but sort of that neutral. Not perfect, I know that, but it does reduce, is the point, from that supination, if you were measuring supination, but definitely the heel inversion, and it goes into a more neutral position, which means that it's going in the direction of eversion. Okay. And so that's what this green corridor is right here. So it looks pretty decent. So let me comment on these two thin lines on either side. So the two thin lines, right? So that's the variability. Now there should be some variability, and that's pretty normal. And what we mean by that is it's not always so tight that it's perfect and repeated over and over and over again. There is some variability, and that percentage, like we saw with symmetry, there's a 5% asymmetry that we're okay with. And it's not only that we're okay with it, it's actually normal. And one of the things that happens, people that have a chronic pathology, is those lines tighten up and there's no variability because they've compensated for that normal level of variability due to their problem. So we see this in chronic pain situations. We see this in other anomalies. So high level athletes, like cerebral palsy athletes, they compensated for that, and they reduced it so much because of their anomaly. So we see it's a little bit wider on one side, a little bit lower on the other side. I wouldn't say that that's necessarily enough to think that it's a problematic. But what we do see here is this trajectory. And so that trajectory of her foot is After she's going and approaching that toe off position, she's really turning her toe out, or excuse me, her heel out, going into heel eversion. And if you look at the literature on that measurement, specifically related to the forefoot in pronation or supination, that's highly related to pronation. And that's one of the reasons that we call this the pronation supination angle is we are measuring the whole foot, right? So we're not technically measuring just pronation and supination, but there is a relationship to that foot position, especially when we're wearing a shoe, okay? So what does that mean exactly? This is a little bit problematic because that causes her to go into a much more valgus position at the ankle. And what that does is that also causes an increased knee moment. All right. So that's one of the reasons that we care about, having too much pronation in this foot position. So this was interesting because when I first did the history on the patient, I like to do the history first because then it gives me some thoughts when I'm doing this analysis on someone, and then I show them the data after the fact. And so, we were looking at this, and I said, okay, so there's definitely some asymmetry here. And that's another characteristic I always look at is if this was equal side to side, this may be how they are, right? I'm not saying it's right, but it could be how they are. And this is not something that happened most recently. Okay. But because there is an asymmetry here, and you look at this, and we really do have a low variability here. And that, like I said, it usually indicates that there's some level of chronicity there, right? Someone's adapted to and overcome something. Okay. And I'm going to come back to that in a second. And now we can look at the foot progression angle and the circumduction. So the foot progression angle is the amount of toe out position, right? As they're going through that swing phase and then they come in ground contact again, right? So that's in the Z axis, right? And and I get this question, and oh, we actually changed it. And I get this question a lot because the variability is huge, right? So when we look at what's considered to be normal gait, a better term would be to describe ideal gait, right? And so most of us would agree that most of the patients in the ideal foot position pattern of foot progression angle is probably somewhere between 3 and maybe 8 degrees. So even static posture positioning is shown to have a toe out position of somewhere between 8 and 10 degrees. It's usually a little bit less during gait because during dynamics, right, we're trying to stay a little bit closer to that mid sagittal point to maintain balance. Okay. So we could arguably say that she's a little bit too much having external rotation at that 9.4 degrees. Now, the reason I say it's too much, and like I said, you could see standard deviations in the literature, out to 15 degrees. But I think here's what's more important is when you compare the right to the left. If she was at 9.4, within that on both feet, then I would say, okay, again, that could be what might be normal for this particular person. But we can see here that she's at 9.8, 9.4 on one side and 3.8 on the other side. So she's more than twice on that side. What's interesting as you start to increase that toe out position too much, it actually affects your heel strike pattern. And quickly, you may still heel strike with the typical supination, but just because of mechanics, you're going to quickly go into a more pronated position. So let's look back up here for a second, right? And that's exactly what we see here. So negative 14.9, but she transitions quite a bit and does start to find a trajectory of going into that heel eversion and pronated foot position. Okay. Circumduction, she's pretty much the same on both sides, so I don't see any problem there. Now we can look at the ankle position on toe off and heel strike, as well as the clearance. Yeah, it's a little smaller on this side, and there's a little bit difference between the two. I think that's a hard one to really consider, and what's going on. If it's really dramatic, then I'll look at things like ankle range of motion, for sure. But we see on the right that, in her toe off, she doesn't seem to go into as much plantar flexion, right? She does seem to reach a little bit further and go into that heel strike position with a greater degree than we do on the left. And again, we're seeing some patterns here where on that right side, we do see some differences and abnormalities to the foot position. Let's go back and look at this for a quick second in the general view. So that was foot position. And then we see this over here, and that was the propulsion rate. So what am I getting at here? Well, whether or not it's the foot position that started it, whatever's going on, it seemed to be part of the answer to the question in why she's not using her hip flexors and has some low core stability. So after I'm explaining this to the patient, and especially saying, you have a foot problem too, and it's causing some issues in the forces being generated during your walking pattern. And if you're not already having some knee problems, then let's take that under consideration, and let's hope that we can take care of that. And this is when the patient responds to me and says, "Oh, I forgot to tell you," right? You ever hear this one? "I forgot to tell you, I had surgery on that ankle. So I do have a fusion, um, and also have some weakness issues on that knee." And she was explaining that her earlier therapy, they told her to do something like that. And I said, "Well," I said, "I appreciate that, but that could be part of your problem with the knee, with your low back pain." Although I wasn't convinced that that was, but I was convinced that she was having some issues definitely with that foot. So I mentioned earlier that I purposely had her walking slowly, where she should be able to do fairly normal, especially as an active person. So let me pull up. I decided to do another one, and I had her walk faster this time. So there was no treatment that occurred with this patient. Okay, so this is the one I just showed you over here on the left, and then the one on the right. So this is actually having her walking at 3 miles an hour. Again, this is on a treadmill because I wanted to control the amount of stress that I was introducing into this patient. As you can imagine, so this is the slower speed, this is the faster speed, right? As you walk faster, you're going to have a longer stride length, right? So typically we'll have an increased cadence. We're also going to have an increase in stride length, right? So she did walk faster. She also has an increase in cadence. That makes perfect sense. So that's really not the issue. We do see that she's actually quite symmetrical when we're looking at the characteristics of the contact phase, right? So at 3 miles per hour, we see a lot of this normalizes. And so um, when we get her walking faster, we find that most of them are essentially within the screen. And again, that makes sense because we're walking her at what's considered to be the normal average speed for this particular person. So let's look at her gait line. And when we look at her gait line here, we see that the trajectory, it's almost the same, right? It's a little bit different on this side, but that's not that unusual that she has a slight deviation, especially when you don't have them go for extended periods of time. So she still seems to be a little bit on the inside, on the medial aspect. And then we look over here and we look at her propulsion rate. So we still see some abnormalities in her propulsion rate where she's still using that strategy of her lower extremity, her plantar flexors as we're moving into that. Now, what would have been interesting is if I actually had her walk at an even faster pace, what's considered to be normal, to see if that actually helps to recruit her, which I don't have it on this. I have it on a different account, but we actually did do that. And we saw this go back to this again. So we're still at 8 and 7% of unusual loading in the plantar flexors, and it actually increased again as we started getting her to walk faster, and we actually were able to elicit some discomfort in her lower back as well. Now let's look at the foot trajectory, the pronosupination angles, and let's put the graphs up, right? So this is the one that I just showed you. And this is the new one. So when we had her walking faster, basically it was the exact same pattern. So she wasn't improving, and we really had the same issues as we did when she was walking slower. So she's definitely involving some compensatory strategies as a result of what's going on. Also, in the foot progression angle, we see that that remains also very similar. So again, when we have her walking at that normal speed, she still has that trajectory of that toeing out pattern that we saw over here in the slower position as well. Similarities in her clearance and steppage. Again, I don't see too much of an issue. They're fairly close, but same thing. She does not go into a lot of toe off position when she's moving through that. So the strategy for this patient, we were addressing her core stability issues, and we also needed to address what was going on with her feet, right? And so as a result of doing both of those things, the first thing that we did was we wanted to correct her walking pattern. The reason I do that too, and when we do corrections, sometimes it's either an insert, changing their shoes, whatever the case may be. And the reason that we want to do that is when you're going to introduce someone into a therapeutic pattern, the rehabilitation program, you want them to do it as best as they possibly can. And so I like to use walking, and I tell patients that walking is a really good activity that they can also do on their own. The problem with it is it's very repetitive. And if you have a bad walking pattern, it ingrains that bad pattern. So we want to fix that. And there's some great studies out there that showed that that was the only thing that they did is they took people with nonspecific low back pain and they corrected whatever. The corrections were different depending on the patient, but all they did was try to normalize their walking pattern. And by normalizing their walking pattern, they saw significant improvements in their condition of nonspecific low back pain. So that's a really good thing. So fixing that and then providing, the benefit of doing the additional exercise therapy specifically for her core stabilization. All right, a little over 30 minutes, but not bad. Okay, so what we can do now is if anyone has a question, we do have a chat. We also have a questions section over there too. And Ron is going to come back up. And so if you have any questions.
In fact, I don't see anything in the chat or in the questions tab. So if anybody has any question, would you please type them in?
Either everyone's sleeping or I did such a good job, there's no questions. Okay. But you know that you can also reach out to us at another time. Keep a lookout for next month, and we will post what the specific topic will be. I think we decided on that.
There's a question by Bernice. How I can know if there's a difference in the leg length in the symmetry?
Oh, yeah. So that's a good question, and it's symmetry that I use as sort of that characteristic to determine whether or not I really need to measure leg length. The other thing that you will look at is the stride length. You'll also see some stride length differences as well. And so, how long would it take to re-educate? Okay, well, sorry, I got sidetracked on the next question. And so you will typically see an asymmetry in the contact time. So you will see that in leg length discrepancies. And then your best option really is to actually go to the next step, which is to measure the difference between the two lower extremities. I use both methods. So from the ilium, as well as from the greater trochanter to measure those two. So that way you can get a sense of whether or not it's anatomical or functional. Now, especially if you're dealing with patients that had joint replacements, more commonly in the hip, we tend to see leg length discrepancies. So in that shorter leg, what you may see is actually a shorter time spent on that side. You'll also see a co-commitment increase in the time spent on the opposite side. So you get this little sort of hitch, and they have to propulse more quickly on the short leg side. So they'll spend less time in contact with the ground on that side. And so that's one of the ways to show potentially that there might be a leg length discrepancy. But be careful, because sometimes if people are experiencing pain when they come in contact with the ground, you will actually see that they will also have a reduced contact time because of pain. How long would it take you to re-educate this lady in more? Oh, so what happens, like in that particular patient, Paula, just putting an insert. So I like to use the smallest change possible, because her problem was actually in the toe off position. She was going to benefit from a full length insert. A heel change wasn't going to do that, because on heel strike she was fairly normal. So you could start with a heel lift. I always like to start with the smallest thing possible to reduce the amount of change that we actually make into the patient. But I knew this patient was going to need something more quickly, or excuse me, more full length, just because of where her issue was going to be in that toe off. So it's almost immediate. So what we wanted to do was correct that. And then and I use a kinesio tape too, just for proprioceptive activity. So she was told, some exercises to try and focus on that knee and foot position in ground contact. But with the insert, like, she wasn't able to do that without the insert. She was able to do that in a normal stance position, but that's not the problem, right? The problem is the wear and tear that happens during dynamics. So with the addition of the insert, so we're almost able to correct her gait very, very quickly. And then what we do is I use tape, kinesio tape, to help support that. Or you can use a knee sleeve. Some people use braces, and then retest her. So that way she can make that connection. She can actually see herself. Another thing too is you can just use your video feedback on a cell phone or something to show the patient exactly how they're walking, so they get that feedback and know what the good position or what the bad position was. And did I answer that question? That can help me decide to put it here. Yeah. So in this particular patient, it may not have helped, but I've had other patients where their problem is on heel strike, and usually a heel lift on someone that has a short leg, for example, a heel lift might do it for you. but you also might need something a little bit more as a mid or a full length, because once they go from heel strike into that foot flat position, and as soon as they heel lift, that heel lift is no longer going to really help them with their short leg syndrome. So you might have to use a full length, but absolutely, you could start with just the heel lift and then transition to something longer if necessary. Cool. Oh, Bernice is typing.
So Bernice is typing something, but I would like, in the meantime, to tell you that we're gonna have a webinar with Chris next week. I think it's at the same time, right, Chris? No, it's one hour earlier than today. So it's gonna be at 6 p.m. France time. I'm gonna put for you the link here in case you want to register. Now, this is basically done for the US, but since it's in English and you might be interested to join, so you're welcome to join us. I'm gonna add the link here in case you would like to register.
And I'll probably do my hair nice too. So.
So Bernice is just saying thank you. I don't know if anybody else has some questions, but I have put in the chat our email, so education@digitsole.com. Please feel free to email us with any questions, requests. If you would like to share with us any specific case that you have measured using Digitsole Pro and you would like to have Chris discuss that, and particularly you're welcome. We would love to hear back from you, and either to discuss in private or to make it the topic of a future webinar. So thank you so much for joining us, and hope to see you next week and next month. This is, as you are aware, it's a recurring webinar happening every second Thursday of the month. So we're gonna see you on December 8th, if I'm not mistaken. Looking forward to seeing you. Thank you, Oscar. Oscar is also one of our team members. Thank you, Ellie. And looking forward to seeing you all next Thursday and next month. Cool. Have a nice evening, everybody. Thank you, Chris. Thank you so much.
All right. Bye-bye.
Thank you, Oscar.
Great evening to everybody. Bye.
Take care.